Good morning, everyone. This is Tanya with the TEACH project. Before I continue, I just want to make sure you can all hear and see me. If you could please type in the chat box. Wonderful, thank you. So welcome to today's Lunch and Learn webinar session. The topic is harm reduction, and our presenter today is Dr. Peter Selby. So if you are interested in obtaining a letter of completion for today's webinar, you must have registered and completed the pre-learning assessment. Sign in to view the live webinar session using your first and last name, and complete the evaluation and post-learning assessment following the webinar, which will be emailed out today. These webinars are being live tweeted. Follow the CAMH Nicotine Dependence Service on Twitter at @PSQuitSmoking. Follow the live tweeting or to post your questions or comments, please use the following hashtag #TeachWebinar. Dr. Selby is the Director of Medical Education and Clinician Scientist at the Center for Addiction and Mental Health. He's a professor in the Departments of Family and Community Medicine and Psychiatry Faculty of Medicine and the Dalla Lana School of Public Health at the University of Toronto. Okay, and I'll let you guys read the rest. You have a copy of the slides as well. These are our disclosures, Dr. Selby's disclosures, the TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as a verbal presentation and any discussion, set out only general principles and approaches to assessment and treatment, and do not constitute clinical or other advice as to any particular situations, and do not replace the need for individualized clinical care. Okay, before we begin, we're going to go through a few polling questions just to gauge the audience. Okay, so the first question is, what region are you from? Okay, 30% is from the GTA. Great. The next question is the type of organization you work for. And the majority, 23%, are from a public health unit. And the last question is, what discipline do you belong to? Great. And about 35% registered nurses. Okay, so now I'm going to hand it over to Dr. Selby.
Thanks, Tanya, and good afternoon, everybody. Thanks for joining us this afternoon. We're here in the TEACH offices and at the Nicotine Dependence Services in Toronto. It's pretty dull and dreary outside, so hopefully this is not going to put you to sleep. We really want to talk about a couple of issues around harm reduction as it applies to tobacco control. And in this session, I want to identify what are the pillars of tobacco control and where does harm reduction fit into it. And then what are some of the harm reduction strategies with clients who are not ready to quit smoking? And what can we do based on the available evidence? So again, here's the polling question in terms of asking you what your views are. And I will just do this. Open. Okay, so we just get people voting. And okay, so we're going to be preaching to the converted. Okay, and I can see it may be necessary, and there's no such thing. All tobacco use is harmful. And okay, so we're going to work with the 5%, and that's fine. I think it's important to have some dissenting opinions about this because as we look at this, we need to make sure that we pay attention to some of the details around it. Coming to this from philosophy versus what is the evidence? Because sometimes if we only come to something philosophically, we don't bring the science to bear, and we may inadvertently have a paradoxical effect, which is we're intending to reduce harm, but we actually increase it. So how do we understand harm? If we take a look from tobacco, there are many ways in which people can have access to tobacco, and one of the things with tobacco is it can be taken in various ways, and people are usually trying to get the nicotine out of the tobacco because that's what is how they want it, and if you combust it, that's one way in which you get exposure to about 7,000 chemicals. If you chew it, you still get exposure to those chemicals, but in a lot less. You don't get the products of combustion, but you still get exposures to whatever else has been added to that chewing tobacco, and or just the tobacco inherently itself has carcinogens built into it as tobacco. The other ways we can get it is just the purified forms of nicotine, and again, that has much less harm. So when we understand harm from tobacco, we have to look at what is the inherent harm or danger from that particular way of using it. So a cigarette by itself, unlit, unused, is relatively harmless, but as soon as you light it and inhale it into your lungs, you just increase the harm. Now, in the short term, immediate term, that one cigarette is not going to cause a lot of harm unless, of course, you fall asleep, set yourself on fire, etc., because you're drinking. But otherwise, the harm comes not so much from each single cigarette, but the intensity by which people smoke and how many cigarettes. So if somebody smoked one cigarette once a year, it would be hard to find and detect any harm from it. But the fact that on average Canadians smoke one cigarette per waking hour, day in and day out, and the smoking exposure goes on for 10, 15, 20 years, this intensity causes harm to that individual. So the harmness of the product, the frequency by which that person is using it can also amplify even small harms into great harms for them. And lastly, at a societal level, if there's lots of people doing a little harm for a long period of time, you'll end up with a large possibility of harm in the population. So when we look at harm from tobacco, we need to look at how it's used and how frequently it's used and how many people use it. So roughly, when we're trying to reduce the harm from something, can we make, for example, the product safer? Can we reduce the intensity by which people use the product? And lastly, is can we reduce the number of people using the product? So that's generally how one can reduce the harm from any kind of product on the market which has a consumptive aspect to it. And you can look at this with, there's nothing wrong with eating or drinking one glass of juice every day in a small amount. But if people end up drinking the whole 2 liters every day, and lots of people are doing this, now you're going to start seeing people with obesity, diabetes, etc. Although orange juice by itself in small quantities is not necessarily harmful. So that's the framework in which we need to understand tobacco control, and harm reduction. And tobacco control roughly and tobacco control strategies since its inception have been very successful in looking at prevention. So how do you get young people from smoking? Protection, how do you protect other people from secondhand smoke or from exposures to advertising, etc. And lastly, there was cessation. How do you get current smokers who are smoking to stop? For a short time, Canada had harm reduction, and then it fell off when Stephen Harper was in power, and it got taken away from the tobacco control strategy, and sort of harm reduction disappeared off the discussion. And what we are trying to do is trying to make sure that harm reduction actually has got a place as we look at the changing prevalence of smoking. Now, harm reduction becomes a controversial topic because there's lots of proponents, especially people who've been in tobacco control for many years, philosophically come to this and say, you're giving up too early. Why are we can have cessation. I mean, we have populations where the prevalence of smoking is down to 3%, so why can't we do that with the whole population? Some people feel, well, we are admitting defeat and giving in to tobacco companies. They win because they've been pushing the harm reduction philosophy right from when the 50s and 60s, when cigarettes were found to be harmful. They said, well, we'll reduce the harm by putting a filter, and many health advocates bought into that. And actually, we've landed up seeing that, in fact, the harm has actually increased rather than decreased. So there's some problems with that. The other question is, in people's mind, harm reduction means that the people still continues to use tobacco products and smoke them, and that we're just renormalizing smoking as a behavior, and we should be actually completely denormalizing it. So harm reduction at one level sort of seems to be permissive. And the other thing is that there's no safe level to tobacco smoke exposure, because we know secondhand smoke is harmful. And even with chewing tobacco, there is harmful elements of exposure, even at any level. So why would we say that people should be using that? The other thing is that many people can quit, and almost everyone can quit, and many do without even any formal help. So why would you say harm reduction? And likely by sending a message of harm reduction, are you going to harm those people who would have otherwise quit completely and said, well, now that you're giving me an option not to reduce rather than quit, I'll just keep smoking but at a lower level. And these people may have actually quit altogether, and now they're not getting the full health benefit from quitting completely. The other thing is harm reduction, does it actually draw young people in with products they believe to be safe? So, I mean, we've seen this idea with marijuana use going up that, well, marijuana is medicine, it's medicinal, it's much safer, it's not as addictive, and so young people start buying into that and start using it because they believe it's safe. So those are some of the issues that make this topic of tobacco harm reduction controversial, and hopefully through the seminar or webinar today, we can have some discussion around and some clarity about these issues and how to think about it, especially when you're working with an individual who's coming in with you and hasn't quit, is having difficulty quitting, and or is asking you about, or is not interested in quitting and asks you about a harm reduction strategy. For those of people who've been sort of anti-harm reduction in tobacco control, we need to take a step back, because tobacco control has always had a harm reduction perspective. For example, its protection policies, such as smoke-free policies, taxation, doesn't tell anybody explicitly don't smoke. What it says is, we're going to make it not that, we're going to have smoke-free ordinances so that those who don't smoke aren't exposed. Taxation is just a price issue about reducing consumption, not about quitting. So there have been harm reduction kind of philosophies within tobacco control, and moreover, there's support for harm reduction from obviously CAMH, OMA, and generally many addiction agencies and others are embracing harm reduction as a way of approaching people than simply a quit or die. The quit or die approach is generally irresponsible, unethical, and unrealistic for some smokers, and we are beginning to see the decline has sort of plateaued off. It's asymptotic. The slope is kind of flattened, and most people who are going to quit generally have quit more than 5 years ago, and the long-term quitters. And so we have many people who are highly addicted and have low cessation rates. So why are we allowing people to accrue risks to themselves from the exposure to harmful products when there are less harmful opportunities of possibilities. So thinking about harm reduction, what are some of the practices that can reduce harm? What are some of the policies that can reduce harm? And what are some of the products that can reduce harm? And so we'll spend the rest of the webinar talking about some of those things. So in general, harm reduction suggests that we're not aiming for perfection in the sense that you have to do that to be cured, but what we're saying is you don't have to be completely abstinent, although abstinence may be the healthiest choice. If you're not able to achieve that, what are some of the things you could do to reduce the harm? Now, public health, interestingly, has adopted harm reduction in its approach to things like HIV, Hep C, injection drugs, and prescription drugs. But somehow when it comes to tobacco, it is still an abstinence-based model that we follow. And it really is an interesting, if we can take a public health approach to this and help people improve their health overall, because it's non-judgmental, non-coercive, the end user is engaged in the creation of the programs they use. So it's not what we think you need, but what is it that you will use and what you want. We also, within a harm reduction philosophy, value somebody's autonomy. And again, by part of its its definition, it needs to be culturally sensitive. So one way to think about in the clinical setting, if you're taking a harm reduction approach, and what that means is that you're saying, I understand where you are today, and I'm willing to engage with you with where you're at, and let's focus on what you value, which is maybe reduced harm to yourself, financially, health-wise, whatever it might be. I'm willing to hear your point of view and help you move from daily use to reduction to continuous abstinence as appropriate and as you're able to do that. And what that does is it engages, and more importantly, doesn't disengage people from the process of quitting. The whole idea of making incremental change by reduction can potentially increase confidence, and roughly what you're doing is changing the behavioral patterns around the use, thereby reducing the exposure. So in a sense, it's a very helpful frame to frame how we approach people in a more person-centered approach. So what are the benefits of intermittent quitting on reducing death? So for example, we do have data from the lung health study. It's the largest study done of its kind, and the paper was published in 2005, whereby you can take a look at if people continuously smoke, the salmon-colored bars shows that you're getting more harm. Intermittent quitters actually have benefit from health benefits from quitting, even intermittently, and compared to continuous smokers. So the sustained quitter generally gets a better health. Now the other cancer one is a bit of an anomaly, but these are not statistically significant. But for the rest, the major killers, you can see that there's clearly benefit from abstaining completely, and as opposed to, but intermittent quitting also has some health benefit. Now, I noticed there's some conversations happening on the side, so I'm going to just pick up a little bit on that. The issue is about no smoke is something not many people consider, but they should absolutely. What's the exposures to the rooms in which this is and you're exposed to and picking up deposits of carcinogens and nicotine, and especially for kids and pets who may be much more closer to the ground and touching the ground. York Region has some great advocacy for harm reduction strategies. That's good. And Alton was talking about traditional use of tobacco compared to commercial use and the risks associated with it. We do have resources out there to talk about traditional aspects of tobacco use, but remember, through TEACH, we have something called its time. The manual is free. It's been co-created with people from First Nations and Métis and those Aboriginal groups, and so it could be looked as a resource, and it does speak to how to think about traditional versus commercial use and where it's relevant. Not all communities look at it in that way. And I think if a person is traditionally smoking meat, is there harm being done to the individual? I think it's a good question. I mean, when we smoke anything, in the long run, you are exposing yourself to smoke, and smoked meat. There is some data coming out that it is in excess does cause harm. Okay. So I'm going to just go back to the presentation and make sure we've caught up there and look at effective harm reduction strategies. So ways in which we can reduce harm when people are going to use something. We can regulate the product. We can have warnings. We can make them taste bad. We can have them in plain packages. We can have it only sold to adults, not minors. So all of those things can help reduce the harm of a product. The other one is changing the nature of products containing nicotine. In fact, are there ways to have nicotine be reduced in cigarettes? But there's two camps. One believes that by reducing the nicotine in cigarettes gradually over time, you end up weaning people off completely as a population. On the other hand, some people feel because you can compensate with cigarettes, that you should actually put very high doses of nicotine so people smoke a lot less, and the jury is out which way to go. But clearly, for example, there are the way in which tobacco is cured and prepared. You could reduce the nitrosamine load by making just a simple aeration process of curing the tobacco that does not allow these nitrosamines to build up, or you can eliminate them. Again, taxation is again important. There's another way to do that. We talked about visibility. Medications are good harm reduction strategies and can help reduce the harm from smoking. And again, in the past, we eliminated the sales tax on Ontario nicotine replacement products, but it's come back as HST. So we've lost that ability for people to make that decision as to which way they were going to have nicotine. So differential pricing, maybe this last bullet should talk about differential pricing and making the least harmful ones more cheaper than the more harmful ones. And these are all ways in which we could roughly say the product change, the policy changes, and the practices that can help reduce the harm from tobacco in society today, at the individual as well as with the community at large. Now, let's take a look at nicotine replacement, because nicotine replacement is the most cleanest delivery system, and it's most consistent because it falls under a framework of a medicine, so it has to get manufactured under a particular way and consistently, which means if a patch is going to deliver 21 milligrams today, it needs to deliver 21 milligrams, and whether it comes from the same batch or a different batch, if it's used immediately, if it's fresh, or whether it's closer to the expiry date, it should be delivering that amount. So those kinds of standards are built in, and therefore you're getting consistency, and safety comes from that. It doesn't have other carcinogens, etc. in it that could be causing harm. So the cleaner, safer delivery system of nicotine separates the addictive behavior from the harm, which means, by eliminating, just simply by moving away from a smoke form to maybe a transdermal form, you're eliminating the risk for COPD, lung cancer, etc., just by doing that. Not to mention the risk reduction from no carbon monoxide and heart disease and damage to the linings of to the lining of blood vessels, the endothelium. So you can see that by simply separating the addictive the behavior from the harm. Nicotine replacement has a huge role to do that. It also potentially, depending on if used in adequate doses, can help people not use tobacco products to help reduce withdrawal. Using nicotine replacement and harm reduction paradigms, so when people are not ready, it may increase their familiarity, and the person discovers for themselves, says, well, wow, when I use the gum or the inhaler or the mist or the patch, I was able to actually not have to go out and have a smoke, and I was much calmer and I felt a lot better. So these people often can benefit from looking at nicotine replacement for harm reduction. Again, nicotine replacement can be combined with other treatments, behavioral, emotional triggers, etc., so that the person can reduce the number of times they expose themselves to tobacco. And again, more and more literature is beginning to get consolidated that suggests that starting nicotine replacement 2 weeks before the quit date may be better than starting it on the quit date. And what this points to is that it's, smoking with the patch on is safe and can be done. And in fact, if you look at this reference, this is from 2005. In 10 years, we've got much more data to support these issues. So we know more, and we suggest that we need to look at it. So what is the hierarchy of harm reduction? Obviously, avoid initiation, full cessation if possible, substitution of the least harmful alternatives, medical nicotine if available, substitution of moderately harmful alternatives, smokeless tobacco, and substitution of the most harmful alternatives, so modified cigarettes, so low nitrosamine cigarettes, reduced smoking, all of those things. Now, where do ENDS or electronic nicotine delivery devices come in here? And right now, it's not clear whether they come in as a medicinal nicotine, which they don't, or do they come in here, which is a substitute? Do they come in here as a substitute of moderately harmful alternatives? And maybe they're somewhere in between. They're between least to moderately. So, electronic nicotine devices will probably fit in here, but because they're not manufactured to any regulatory standard and because of the dangers, we're not sure where they should go. But under ideal circumstances, if they were able to come in as good manufacturing practices, they'll probably come in somewhere here. I hope everybody can see my green arrow. So what's the context of the harm reduction debate? We have limited success of prevention and cessation. Though it's been successful, there's still 5 million smokers in Canada, approximately 2 in Ontario. There's a perception that we are dealing with these hardcore smokers, although that's not necessarily true at a population level in the clinic. It does certainly feel that way. And we have some new, competing demands of the harm reduction debate. The industry is publicly acknowledging the dangers of smoking is harmful, but continues to sort of undermine some of the efforts. But many tobacco companies, USST, is trying to promote smokeless as less harmful, as well as electronic nicotine delivery devices as less harmful. And so we've got this huge context emerging in front of us, and we need to think about how to come with it. So there have been these innovations, and not necessarily driven by governments, but novel tobacco products are both. Some of them not are spuriously, have less harm, whereas others actually may have increased harm, and then those which have potential to have a lot less harm, maybe 95% less harm. And there have been innovations in these products. So I think we need to start looking at this debate. It's not a simple one because there are all these competing issues going on in the background that creates a very unstable environment. And therefore, there's a concern about promoting harm reduction, primarily because the tobacco industry has been in this space before. Healthcare practitioners have bought into the harm reduction, and it hasn't panned out, especially with the light and mild cigarettes. It was simply something that fooled the machine, but not the people. And in fact, because of the way it was produced, sometimes, for example, the lung cancers that were beginning to develop were much more deeper into the lung than when people smoked traditional cigarettes, so making it harder to operate. And so, again, we have to be cautious how we come across harm reduction. So what are our motives? We want to reduce the risk of death, who are incapable and unwilling to quit. The industry wants to sell a product on a sustained basis with the goals of profiting from sales to consumers they may otherwise lose. So there's that other commercial interest that's driving this. And the industry, pharmaceutical industry, and I think the vaping industry comes in between, is they want to, for some vaping industry people, which is separate from the tobacco industry, want to come and eliminate the tobacco industry completely. And the pharmaceutical industry is a bit skittish because they sell products on a short-term basis, but they don't really think about long-term nicotine replacement, which is odd. So I think we need to pay attention to what role does the pharmaceutical industry play in this whole harm reduction debate, because long-term medication doesn't seem what people are willing to do, but maybe they're willing to switch to a long-term vaping device. So the jury's still out and what people are doing in the real world, but we're beginning to see some blips here. But at the end of the day, from a public health perspective and from a healthcare perspective, we want to reduce the risk of death and disease who are unwilling or incapable of quitting. Now, reduced smoking by itself, lots of people who are just cut down, does not result in less harm necessarily. And this example shows that as people go down and go up, of course you're at greater risk of developing the more you smoke, but it's not exponentially less as you go down. And so, so what we want people to understand here is that although there may be a behavioral benefit by reducing the number of cigarettes, people shouldn't walk away thinking by just reducing the number of cigarettes that they're reducing the harm to themselves, because there's compensation. They may take deeper inhalations. They may have more per cigarette, even though they may be smoking fewer cigarettes, because as you know, cigarettes are very elastic. You can smoke them heavily. You can smoke them lightly. So that's the combustible form of tobacco that we have, that's what we are up against. And then there are other forms of tobacco which do not involve combustion but have been used, and sort of there are three things, which is snuff, which is fermented, ground up, placed between the bottom lip and gum, and it's known as dipping. And in the Swedish form, which is specific, it's not the same as the American and Canadian form, something called snus, and that is associated with a lower risk overall than snuff, as well as smoked tobacco, but it's not without its own risks. Chew is shredded tobacco leaves placed between the cheek and gum, and it's also referred to as a wad. And the plug is which are pressed into a hard block and again pressed between the cheek and gum. So that's what a plug looks like. This is what chew tobacco looks like, and this is what snuff looks like. In any of these smokeless tobacco products, you get obviously the nicotine, but you get the carcinogens as well, except the ones that are in smoke. But look at the sweeteners. So they are heavily sweetened with sugars and promote tooth decay. They have abrasives so that you can get a higher absorption of the nicotine. High salt. And so this is really problematic, and especially in some people who live in northern communities, high risk of diabetes and kidney disease, and are using salt and are getting dialysis, and and are wanting to get onto a transplant list. And this use of smokeless tobacco is problematic. Not to suggest that they go back to smoking, but there may be ways for them to benefit from using other forms of clean nicotine that doesn't have all these other chemicals. Smokeless tobacco has all these other issues of mouth cancer, throat cancer, and heart disease, dental disease, stomach problems, loss of taste and smell, physical changes. What is most concerning to us is obviously these cancers, these head and neck cancers, which are quite horrific. Now, of course, the advances in treatment have made it a lot better, but again, it's a horrific cancer to get, and certainly is something that we want to avoid and is avoidable. snus is a special case. It comes in these little pouches, as you can see here, and basically it's a moist smokeless tobacco and snuff. That means it's maintained in a cold chain. It's pasteurized almost. And it's different from other chews. It's sterilized. It has a decreased number of nitrosamines or cancer-causing chemicals, and clearly has been associated with a reduced risk of lung cancer and no emphysema. However, and this is compared to smoking, however, it's associated with an increased risk of pancreatic cancer. It's twice as much as non-smokers, but it's less than smoking. So for example, in Sweden, it's probably a good product, but in Canada, where it's co-marketed as, here's something to use when you can't smoke, it's probably, or it's here's, let's start you kids off on something and then you move on to cigarettes, is not appropriate. So again, that's why regulations that bylaws that prohibit flavorings and appealing to youth are going to be important ways, because you'll end up otherwise causing harm to the youth while maybe a few people get benefit who can't quit. So smokeless tobacco actually sometimes leads to higher levels of nicotine and can be quite dependence forming, and sometimes people are using it through the day because there's no break, because they just can do it discreetly. They develop cravings and withdrawal like anybody else. And again, in some communities where you have high prevalence of infectious disease like tuberculosis, you don't want people to be spitting and chewing where they aerosolize all these bacteria into the air. So that's one of the concerns with this, because it doesn't induce spitting, and that's why the snus people have created this little tea pouch kind of thing where there's a pouch you put in and you take the pouch out, and like a tea bag, you just dispose of it, and so there's no spitting involved. One of the things we do know about snuff and smokeless users, they tend to be male, mostly male, and below the age of 18. But there's about a 10 to 20% co-use of cigarettes. But this is getting close to 1 in 3, almost 1 in 3 users will develop oral lesions within 3 years of using. And these oral lesions are called leukoplakia. And leukoplakia is a precursor for cancer. So if you do have chew tobacco users in your practice, make sure you're doing a good cancer check of their mouth. And if you see any lesions that are not going away, definitely get them to see a surgeon or a dentist who practices that kind of dentistry to make sure a biopsy is done, and strongly advise them to quit or switch to another form of nicotine. Out of the cessation with smokeless tobacco, the study suggests the lozenge, high-dose nicotine patch, a varenicline, and all of them can work with this population. Again, opportunistically, when there are lesions, use that as an opportunity to motivate behavior change, but remember these are addictions, so addictions by its definition is continued use despite harm. So you use that teachable moment to engage the person in the dialogue to get them to make a quit attempt. And again, I can't emphasize enough that this issue of these oral lesions, if they do not heal within 2 weeks, recommend a biopsy, get them to see somebody, because early detection is an important part of oral cancers as well. Clearly, oral cancers go up much higher in smokers who also have HPV, and so and drink alcohol. So I guess if you're having somebody like that, their risk is getting exponentially much higher than somebody who has any one of those risk factors. So looking at smokeless tobacco prevention website, and it's both for quitting, My Last Dip, and so these are resources for you to use, share with your patients as you might need. Well, what about the shisha or hookah? The shisha is a mixture of tobacco, molasses, fruit flavors used in a hookah. You can get non-tobacco containing shisha, which has only molasses and fruit flavors, but regardless, lots of people believe that it's bubbling through water and that's going to purify it. The bubbling through water is just to make it moist. Everything that's in that, smoldering embers over here at the top, where it's heated and burned, is making its way through you and into smoke. And if you look at an hour session of hookah smoking, you get about 100 to 200 times the volume of smoke that you would get from a single cigarette just because of what is produced. And it again has carbon monoxide, heavy metals, and other carcinogens, can deliver significant levels of nicotine if it has nicotine in there. And again, has been associated with lung cancer, respiratory illness, low birth weight, and periodontal diseases. What is fascinating to me is that a lot of people consider this as a cultural practice, but this doesn't look anything like a cultural practice, but it is roughly what people are co-opting in cultural practices and promoting as that way to gain protection. Interestingly enough, in many Middle Eastern countries, hookah smoking is being banned and dissuaded in public as well. So it's not that it's a cultural practice. It used to be used by lots of people in a cultural context, but again, is no longer valid or reasonable given what we know what the harms are from it. Coming to electronic nicotine delivery devices, the focus really is on this emerging market of electronic cigarettes, also known as electronic cigarettes, but it's probably a misnomer. Maybe the first generation, where they look like cigarettes, is a true name. But as we move to the second generation, third generation, where they look much more like batteries and high-powered devices, calling them electronic cigarettes is probably not a good idea. And when you're taking surveys or asking people questions about this, you have to know what kind of device they're using before you make any kind of judgment. Roughly, tobacco industry is buying up these first generation and maybe a few second gen devices, but all of these third generation or mods as they're called are essentially small independent manufacturers and distributors. An e-cigarette roughly has an interesting idea that it has a look, three components. There's a cartridge containing the nicotine, which vaporizes which then gets vaporized. It has propylene glycol, may have glycerin, and flavoring agents, about 1,000 different types are available. This atomizer, which is a heating element that turns the liquid into a vapor, so there's no combustion, and a battery which powers this whole thing, and an indicator line to tell you that it's on. And there are variations of that same device. As you know, they are not legal in Canada, however, and here's what it is. The Food and Drug Act suggests that inhaled nicotine cannot be marketed, sold without official approval as a new drug. The only legal form are those without nicotine and have no accompanying health claim, and they are regulated in Ontario by the Smoke-Free Ontario Act, and in some municipal, there are codes of where they can be used. The issue is that this has never been challenged. A law is only as good as what happens when it gets through a court and somebody challenges it. So as it stands now, it's not legal, but nobody's challenged it. And people are flouting this all the time because you can get nicotine-containing e-cigarettes or liquids quite easily on the internet and in vape shops and in some corner stores as well. And the reason is that from a harm perspective, Health Canada hasn't seen it as a large harmful thing, and they haven't gone after these people. They're also afraid if they take it to court, they could lose. So right now we are in this limbo, where it hasn't been tested. So what happens is our patients are being exposed to e-cigarettes without any kind of quality control, with e-liquids without any other kind of quality control, and they believe that they may be getting reduced harm, but we don't know for sure if they're getting any reduced harm. Public Health England came out with a report around e-cigarettes, and I think that's important for us to pay attention to, because it summarized most of the existing data in a very pragmatic way, using a common sense approach, including a scientific approach. So here's what their key messages were, that unsuccessful quitters should be encouraged to use e-cigarettes. The caveat to that in Canada, for me anyway, is that I don't know if I recommend a brand of e-cigarette, how do I know it's manufactured to any standard? How do I know that even if they buy one e-cigarette today, the next day, even if they buy the same brand, it's actually doing the same thing or some other contamination has crept in? So in the absence of that oversight and regulation of the product, I'm very wary about recommending e-cigarettes from that perspective in Canada. It may be okay in the UK where they have much better quality of products and they're maybe more pragmatic about it, but there it is. So The other thing they recommend is behavioral support should be provided to e-cigarette users. And this really suggests that they're viewing this as a quitting product rather than a replacement product of cigarettes. They also talk about, although unmotivated smokers may report a decline in smoking-related diseases by using e-cigarettes, and it's interesting to see what the evidence is. There's clearly cancers and stuff like that will not be reported, but there may be some benefits from, for example, influenza, maybe some benefits for lung functions, may improve, et cetera, but again, small studies on devices that do not reflect what the current devices on the market. So all of these messages may be short-term, may not be valid by the end of 2015. The other one is there's no evidence e-cigarettes facilitate a decline in cigarette use. So, for example, at population levels, we are not seeing a reduction in cigarette use because of e-cigarettes, or that when people switch to e-cigarettes, we have a lot of people who use dual use, which means they won't make that full switch. There's some evidence, not that great quality, that e-cigarettes might help people in quitting smoking. When used as intended, there's no risk of nicotine poisoning. The problem lies is when those flavoring agents are left next to children, produced next to children, the bottle is consumed because it looks sweet and it has good, nice odor to it. So clearly, yeah, if you use it with all the protections in place, it probably won't harm the smoker as the nicotine in it. However, just yesterday, I think there was a story about somebody on a plane. Their e-cigarette was in their hand luggage and inadvertently got turned on and landed up causing a small fire in the person's bag. So these are the issues around product regulation, whereas an unlit cigarette just never self-combusts in hand luggage. E-cigarettes are safer than smoking overall, and they base this on a consensus that suggests that e-cigarettes may be 95%, potentially 95% than smoking cigarettes. And this is the most exciting part, that if we can actually prove this, that there's high acceptability, this model is 95% safer than cigarettes, then you could make the case to ban combustible cigarettes. Again, you need to ensure that the products are safe and children are protected, and more research is necessary. So that's what Public Health England has come out with. Basically, the recommendations are, can we look at e-cigarettes as an end game for combustibles? Can you imagine nobody's using combustible cigarettes? Nobody's lighting matches. Nobody's causing fires because of matches. Nobody's causing fires because they've fallen asleep with a cigarette. There's no secondhand smoke coming out. And there's very little, ambient contamination occurring from the vaping products. I mean, at best, you're going to get some water, and you get nicotine into the air and third-hand exposures, but nowhere next to all the other 7,000 contaminants that you would get from combustible cigarettes. Can we learn lessons from alcohol prohibition by creating a framework for production of clean e-juice rather than the dangerous ones that are now being produced by mom-and-pop shops and who knows who else with no quality control? We need to create a framework in Canada whereby we can study this so that we can actually prove that there's harm reduction with using e-cigarettes. Right now, we are not able to study it to demonstrate harm reduction. Improve the quality assurance and regulate the industry and the manufacturers, and the vaping industry is beginning to be self-regulated. But again, when there's a commercial interest, you do need oversight with government regulation. And again, clearly prohibit where smoking is prohibited. We don't want to have a backslide and having people exposed to things that they shouldn't get exposed to. So lastly, restrict sales to minors, prohibit in public spaces, advertising flavors, education regarding the risks. This is not a fun product. This is not a product for people to try and use to then go on to become smokers. This is really a gateway out of smoking, not into smoking. Again, youth and pregnant women, just like with any other product, need to be cautioned about it. And there needs to be surveillance and monitoring as to which way is this going. There's some emerging evidence in the U.S. that actually as e-cigarette sales have gone up, youth smoking has declined. And is that because of e-cigarettes or other secular trends that were going on anyway, is important. Other features are suggesting that in those jurisdictions that have brought in bans to e-cigarettes, the youth prevalence of smoking has gone up, whereas those where there are no bans, youth smoking prevalence has gone down. That could also be that in jurisdictions where youth smoking was going up, people brought in bans for e-cigarettes. So you can't necessarily say that e-cigarettes are preventing youth from taking up smoking. But clearly there's some interesting research to be done here to help guide policies. So very disruptive innovation product out there from a harm reduction perspective, and clearly in a harm reduction paradigm, as a product replacement, can you replace combustible cigarettes? From a policy perspective, can you create pricing so that it's the cheapest form? In fact, for the poorest smoker, after the initial outlay for the vaping device, which is the large vaping device, the mods, the cost of daily consumption of nicotine is pennies compared to cigarettes. So are there ways that the population can be shifted to less harmful products in time? And these are all things to be decided and determined, and there's a lot of controversy around it. But harm reduction has always been full of controversy, but generally, if we keep the person in mind, the person's health, the person's autonomy, person's well-being, then we can start looking at how do you create this framework for people to have access to these products when they aren't able to quit. So what is the bottom line? It's a changing and evolving landscape, especially with the electronic nicotine delivery devices, and I'm trying to get away from calling them e-cigarettes or e-smoking because it's really vaping, and clearly these are electronic nicotine delivery devices, and so this distinguishes it from everything. They aren't necessarily e-cigarettes. Snus, as I said, is useful in Sweden, not likely in Canada and North America, and clearly there is harm from chewing tobacco and not highly recommended. If people want to have the really clean form of nicotine without any other exposures, then medicinal nicotine is the cleanest, probably the least harmful out of all of the products we have out there because of the way it's delivered and what it delivers. The downside is it doesn't necessarily meet the ideas of identity that people are looking after, or how that makes them feel about themselves, or how they project themselves in public, and the utility of it. So we haven't really done a good job in altering medicinal nicotine for the use of harm reduction. The only thing I know of is that the gum has an official medical indication for short-term quitting in places where you can't smoke. So bottom line with harm reduction, think about it as practices, policies, and products. And in the product section, electronic nicotine delivery devices are the big products. So in the last 10 minutes, I'm going to open it up for questions. I'm going to review back. I'm going to pick up from what questions were coming in so far and see where we can go. Okay. And without question can be useful effect tool in helping reduce harm, especially those not wanting to quit but smoke in a chronic fashion, such as people with addiction, mental health disorders. Yeah, so I think the issue about can and help, the product is not, I think, ready for prime time and wide dissemination in terms from a public health perspective. But from a device perspective, when we're reducing harm in certain populations, for example, many public health units hand out safer crack kits. Those are things put together. They're not necessarily all manufactured to a product device standard. So we can look at devices anyway in those frameworks, and I think we need to start studying them in that way. And clearly in populations who are unable or unwilling to quit, whether they have other mental health or addictive problems or anything like that, the issue is if there's somebody unwilling or unable, what I would like to remind people, addiction to tobacco can be primary. It is your addiction. And you don't need to have other things that make it hard to quit. Just the addictive nature of tobacco itself can make it difficult for people to quit. And can they have nicotine in a way that is safer and cleaner? So in terms of starting NRT before the quit date, the STOP SOR program can be changed to reflect this. Stop has always allowed for concurrent smoking with with nicotine replacement. And so because that's what is allowed, where the difficult decision is, or what it says on the box, especially for Stop on the Road, where we're not having a one-to-one relationship with the person coming in. It's hard to give advice to people without knowing the context. In primary care teams, addiction agencies, or CHCs, or where there's a face-to-face contact and this discussion can be had, the evidence does support it, even though it's off-label, off the box. So clearly that's the nuanced aspects of using nicotine replacement therapy before the quit date. It hasn't made itself onto the official box yet. What is the official dosing guide for patch when you're reducing to quit? That's a great question. Usually for reducing to quit, and typically the studies have been done with gum, but how we've done it with using the patch is essentially we start with a usual dosing of the patch. Greater than 10 cigarettes, use 21 milligram patch. If they come back within a week and they're still smoking, we'll just bump up the patch by the number of cigarettes smoked. So roughly a milligram per cigarette. So they're smoking 7 cigarettes, and we go up by a 7, and help them to reduce. Roughly, you want them to, within a 6-month period of time, have achieved at least a greater, about a 50% reduction in consumption of cigarettes without compensation, which means they haven't just reduced the number of cigarettes and smoking them more heavily, but truly a 50% reduction. And then in the last, in the next 6 months, try to make a quit attempt. So reducing to quit can go several ways. It could be a gradual quit date, or it can be reducing and then having a sudden quit date. So we just work with the patient and the client and see where they are at, monitor them. What we do know, reducing to quit without nicotine replacement simply leads to compensation, and people go back to where they are at. So that's a reduction to quit. You can also use reduction to quit with varenicline and bupropion. In fact, both of them require the start of the medication at least a week to 10 days prior. So the guidance of using medication as a harm reduction is that you don't have to get the person committed to a particular quit date. They can gradually acquire a quit date. And varenicline recruits people into quitting months, more than 8 weeks after they start the medication. So if you're looking at sort of ways in which people can reduce or quit, that's what happens. So pyrazines and e-cigarettes, and so how does that increase addiction to nicotine? It suggests, so I think that there has been some debate as to whether they are there, and again, addiction to nicotine is a complex issue, and I think if I remember correctly, there's been one paper about the role of pyrazines and as to what level they exist in e-liquids and whether they are addictive in nature of nicotine. I think inhaling any form of a drug, whether it has the pyrazine or not, will make a drug addictive. Nicotine is addictive if you take it by itself without anything else into your lungs and get a rapid release of it. But that's a good question, and we will look it up and see if the pyrazine and e-cigarette paper is easily accessible. Right, and I think Bob is really clear that you start off with clients who want to practice quits and making practice makes perfect, and that's really a key issue about when you take a harm reduction approach to people. You start saying where they're at, come alongside them, say what I've always said, which is quitting smoking is a process, not an event, and help them stay in the process and build their confidence at time. So yeah, with respect to contents in e-cigarettes, it's tough to know exactly what's in there because many e-juices found in the convenience stores claim not to have nicotine but can have, nicotine in them because just the manufacturing standards are not necessarily met. So you've got to think about it in that way. Okay, I think we're going off with a lot of questions, and I'm just sort of making sure I don't miss them. Okay. Let's move. Okay. Yeah, so I think Gary has been having a good conversation here, so I'm going to Take a look at some of the comments. Yeah, and I think, again, other behaviors that reduce the harm. We know that when people, for example, sedentary smokers have the highest risk of death. And very, very active smokers who are, for example, running marathons or running an hour a day, etc., and are very fit otherwise, they have a reduced risk of death. And so clearly we know these other behaviors also can affect the overall effect. And we know acute bouts of exercise are very helpful in managing cravings, etc., and reducing the amount of smoke. So yeah, e-cigarettes are widely available, and that's one of the other issues, that they're sold both in convenience stores and in vape shops. And clearly it's not clear where it should land, whether these should only be sold in vape shops or in convenience stores as well. Has propylene glycol in electronic cigarettes been shown to contribute to cancer? No. Propylene glycol is generally considered to be safe as a FDA product. The question is the amount of propylene glycol that somebody who vapes might be exposing themselves to over a chronic period of time. Going back to that first slide of total harm, can I just go to the slide? No, I have to go back. Okay. This one. Here we go. Yeah, that slide. You can see this with the intensity of propylene glycol exposure. Even though it may be relatively harmful, and lots of people are inhaling propylene glycol, you may land up with some harm from it. However, you have to compared to cigarettes, it's always in comparison to something else, not in its absolute. What is the absolute harm? Now, what happens if people believe e-cigarettes or electronic nicotine are safer, and many more people, now 50% of the population are doing this. So although its inherent harm has dropped, but more people end up using it, then you may land up with more harm to society than what cigarettes were causing. So that's why we have to be careful about widespread policies that sort of promote e-cigarettes or electronic nicotine devices, because there's these unknowns that we have to contend with. And is there any evidence of that? No, there's no evidence of that. In fact, actually, where we do know is that propylene glycol in animal studies, in studies as far back as 1947, actually propylene glycol inhaled in animals, not proven in humans, may actually have a beneficial effect in terms of killing off influenza viruses. So, but that is in animal studies, 1947. We don't know the quality of those studies, but the propylene glycol in general is not necessarily. Now, where the risk for chronic bronchitis, the risk of pneumonia comes from is that we don't know how the quality control of how these things have been manufactured, and if people are landing up getting damage from the liquid itself that causes bronchitis and pneumonia rather than the vapor itself. Okay, and we're getting close to the last minute. What we're going to do is there's lots of questions. I think, yeah, if you can check out the UK Public Health England article, that would be great.